familiar with what the SOAP note is. All doctors use SOAP to document their information. They might not put the SOAP, but it is in that order. And our S is the subject of the, or history of the part of the note. This includes the history, the present illness, the review of systems, past medical, family, and social history. The O part of it is the observation. This is that hands-on examination of the patient by that provider. The A is the assessment. This is what the diagnosis the doctor came up with after asking all those questions and doing that examination. And the P is the plan. What are they going to do to make this patient feel better? What's their current plan? Are they going to do future treatment? Are they going to do some testing? They're going to refer them on. That's what the plan is. So now, again, we're going to review, not audit this. And so we're going to be discussing how to review that documentation, look for the errors. And the purpose of this is to verify that documentation to determine all the information is correct and it's billed properly on the CMS 1500. Of course, the UB if you're doing inpatient type of code or hospital facility code. Sometimes I don't notice the documentation errors until I really get started with the audit, but these are really clear, important steps to help identify any possible errors. And the exercises I've given you, it will help you understand the SOAP notes and what you want to review and not review, depending on the information and the documentation. So what are we looking for? Well, first of all, one of the first things we want to look at is the documentation clearly paints the picture of that patient's illness, injury, or condition. And because not everything is, the guidelines are different before 2021, and then 2021, the doctor still has to tell you what's going on with that patient. And we'll get into more detail about that as we go along here. But that first paragraph, I need to know why that patient's coming in. What have they done? What is making them feel better and all of that? So I need that clear documentation to tell me what's going on with it. And I'm going to show you a couple of examples here in a little bit. Is there any conflicting information? And when I say that, I will say, sometimes I'll look at, the doctor says that the patient is wheezing, and then another part of the note they'll say they're not wheezing. And that can be very conflicting. I also work for attorneys and help attorneys with malpractice and also defending doctors as well. And so these are the type of things that you don't want conflicting information because it does not make that physician look good. I'm also looking for patterns and trends. Are they padding the documentation? What I mean by padding the documentation, are they adding information? Let's say in the examination, we're saying oriented times 3. Is that in 3 different parts of the examination? They're not going to get 3 separate points. They're only going to get 1 point for it. Or are they doing more than what they should be doing? For an example, I had one doctor that was a patient had a myocardial infarction. He was a hospital admit. And the doctor said his outside external ears were great. Why would we be examining the ears for myocardial infarction? So, and he was doing that on every one of his notes. So to me, that was just trying to pad the documentation to get more points. And this was before the 2021 guidelines came in. So it's not necessary. Are the notes cloned? We see some, they all look the same. And copy and paste. And copy and paste we'll talk a little bit more about as well. So what I do is I compare the documentation to the CMS 1500, and this is what I mean by location you have. Is the data service correct? I see sometimes errors on that. So is the data service to what it says on the record and the CMS the correct data service? Is the physician's signature identified? Is it the same provider's name as the documentation? Is there instant tube billing? You know, that's a whole new subject, instant tube billing. But if it is the physician, the supervisor physician documented in the medical record as well, and in the CMS 1500? Is the diagnosis the same? I see probably more errors with this than anything else. That what they are billing, CMS, the 1500, is it the same as the diagnosis that is in the chart? And then I'm going to look at the chief complaint. We need to have a chief complaint. And I'm going to show you some great examples that it does not support why that patient is coming in for the day. So very important to have a chief complaint that matches, not just something like other or sick visit, giving information of that chief complaint. The history is documented. You can identify why they are being seen. Again, we don't need all the components, but I'm going to show you the information we do need. Past family social history, is that documented, especially for what they're coming in for? Is the examination documented correctly? You're going to only need the examination. It doesn't need to be a full exam, but for what they're presenting for. Is the assessment and plan, do we have all the labs and the testing with 2021 guidelines? This has got to be much more detailed than what they've done in the past. And then time documentation. This is one of the first things I look at when I'm looking at to do an audit. Is time documented? That means I need to look to make sure what that they have designated. Time really shows exactly what they did during the encounter. Also, very important is the physician's electronic signature. That's one of the things I look at on my checklist when I'm auditing to make sure that their electronic signature is there with the date and time. And then I also look at sign-off dates. What date did they sign off on their medical record? You know, sometimes I will see things that are 3 months down the road. There is no way that doctor, I don't care who they are, can remember exactly what happened 3 months ago to a patient. And this is something I look at, especially when I'm auditing for an attorney. We want to see that they are getting their documentation done in time. So you cannot remember what happened 3 months ago. I don't care who you are. Of course, I can't remember what I had for breakfast, but you know, that's just me anyhow. That's why I retire. Also, I will let doctors know that they need to sign off between 24 to 48 hours. Now, is there a written rule on this? No, there is not. But it's pretty much documented by Medicare that that's what they recommend, that they must be signed off in between 24 and 48 hours. So I always make sure if it's later than that, I will let that doctor know. All right, so the first note I'm going to go over is the one for Daisy Day. It's soap note number 1. It's one of the soap notes that I gave to Jennifer to send out to you guys. So we can see we have the date of service at the top. We have their patient's name, their date of birth. First thing I'm looking at is the chief complaint. It says other. I have no idea why this patient's coming in the door. How's that going to support the medical decision making if it just says other? We need to know, why is that patient, why did they make this appointment when they walked through the door or when they called to make the appointment? Here's their HPI. Debbie's a 4-year-old child. Running, fevers, threw up. Sister came in and said her sister's legs were kicking, has not had one in 2 years. Fell asleep and then went to the store. No more vomiting, denies diarrhea, runny nose, pain with urination. Well, first of all, that's not telling me. I have really no idea why this patient came in the door. This is not painting a clear picture of why this patient made an appointment. And we can't assume anything. Remember that, guys. We cannot assume anything. It must be documented by that provider. We cannot assume it. I don't care if the doctor says that they are a controlled diabetic and have an A1C of 9.6. I know 9.6 is not controlled, but I can't do anything about it. The doctor has to say they have uncontrolled diabetes and use the appropriate diagnosis. So again, it has to be written by the physician. We cannot assume anything. So that history is not good. It's not telling me the chief complaint. It's not telling me why they came into the office. I really have absolutely no idea. The past medical history, this identifies history of urinary tract infections, otitis media, and seizure from the fever. Well, maybe that patient came in because they had an earache, or and then they have a fever with it, and some type of virus, or they had a seizure. But again, I'm just thinking about those, but I still cannot identify why they came in the door. This is a real note, guys. I did not make this note up. This is a real note from my doctor. Then I look at the family history. They have a family history of diabetes with a grandmother. Social history of lives with two sisters. Parents are divorced. They have a split custodial rights. And they always ask if anyone smoke in the house, and the answer is no. So the examination for this patient, it says general appearance, active, NAD, talks about the eyes, the ears, and the ears are good landmarks, so, and there's nothing wrong with the oropharynx, so I know it can't be an ear infection they came in for, because everything looks good here, unless they marked it incorrectly. But I've seen that before. They'll say something looks good, and that's what they came in for, and they give them a diagnosis of it. And a great example again of that is this otitis media. They'll say no earache, or they'll say here they'll say everything looks clear, but yet they use diagnosis of otitis media. Cardio, everything looks good there. Lungs, there's a clear to auscultation bilaterally. Abdomen, no problems there, and the skin is well. So it looks appropriate and correct. I don't see anything, but I'm just kind of skimming over it to see if there was anything in that would support what that history of present illness was. Now we're going to look at the assessment and the plan. And this is what the physician wrote down. Daisy's a 4-year-old child with a history of febrile seizures who had seizure activity this morning, unwitnessed by parents. Oh, but you cannot diagnose it just from the history because it was not clearly marked what it was. She is well appearing in the office with neck supple, also has a history of UTIs. Well, maybe she was coming in for that too. Attempted to give a urine sample, but unable in the office. COVID testing performed, cough, worsening symptoms, neck stiffness, persistent vomiting or fever or concerns. I think that's what the patient is to do. So what they put down for a diagnosis? Fever, R50.9, unspecified. Nothing there tells me, they said she had a fever, but it doesn't say that it is, look back here again. She was running a fever and threw up, but I don't really know. I mean, what was the fever? Was it 102? But what is her temp? I don't see anywhere where it's documented of what what a mother might consider as a high fever. My husband might consider a high fever at 99.5, where somebody else said no, it's 102. Well, there's a big difference there. So nothing tells me what the fever is. They instructed him to give the children's Tylenol, and then it's electronically signed by the doctor. So you can see here, the only diagnosis they used on the CMS 1500 was the R50.9, which is fever unspecified. To me, it is not matching what they came in for, because I really don't know what they came in for, but even the fever's not documented, because you don't have the temperature to say, yes, this is what the fever and this is what the concern is. So this note, I couldn't believe when I read it. I thought, this doctor must have been in a hurry. But what was really interesting about this note is that this doctor was 3 months late on putting this documentation through. That told me they couldn't remember everything that had happened. And I think that's why the documentation read the way it did, because they don't remember that. But take me to you, a real quick story. I had a physician I was working for. He was horrible. This is before we had electronic medical records. I mean, that's back in the cave days when I used to work. And what happened is that he had so many charts on his desk that he just kept putting to the side and not doing them. He had 6 months worth of charts in his office. 6 months. So we had stacks that we had to go through if we would find somebody's chart. It was unbelievable. And so he kept saying, yeah, I'm gonna come in some weekend, get caught up. Well, 6 months worth of charts, you can imagine how much time that would take. Well, what happened is he died in a car accident. None of those charts were done. So they had to refund, and back then they would bill it as soon as he was done with it. They had to refund tons of money. So you never know what tomorrow's gonna bring, but those should have been done. All right, now this is gonna be a real interesting case for you. We're gonna have this patient, Robert Redmond, for an office visit and then a hospital visit. And we're gonna show you how, when I see this, I'm going, oh my gosh, you know, all the problems they have with this one. So we have the data service, and the patient's name, date of birth. I check the CMS 1500 and make sure it matches. And when I audit, I tell them I want the CMS 1500, so I can make sure everything is correct on that CMS and what they billed to what is documented. The provider's name there, chief complaint, acute visit. That tells me nothing. Again, guys, these are real notes. I have no idea what the patient's coming in for. Acute visit, need more specific. Then the nursing's documentation. This is going to be really important, guys, so watch this and as we go remember some of this information. That's why it's good to have the notes in front of you. On November 30th, now they came in on January 1st, but on November 30th, the patient weighed 159 pounds. On the January 12th visit, he weighed 129 pounds. Whoa, what's going on? Talks about their oxygen at rest rate. They were unable to get a reading on the oximeter due to the cyanosis the patient had. They attempted twice, but they were unable to get a pulse ox rate with him. The day he came in, he was short of breath, and he had a portable O2 with him as well. Fever was okay. History, no history of gout, but for symptoms and pain and feet, discussed results of arterial ultrasound, which was normal for the upper extremities, complains of some fatigue and thinks it's from waking constantly due to the foot. So he's got pain. Everybody want to mute, please? So he complains of the fatigue and the walking, but the chief complaint should have been foot pain or whatever, not acute visit. Acute visit tells me nothing. And then it says in there, discuss results of arterial ultrasound. Well, what was that all about? I don't show that anywhere he was talking about it or had him get the information, but even if it was in the visit before, I would still put in there why he had the ultrasound, because I don't know what it was, and it says just normal, so not going to give me any points in reviewing. Review systems. This is interesting. Denies the negative for the following: fever, chills, headache, double vision or blurry vision, ear pain, throat pain, nasal congestion, fatigue. Well, he said right here he had fatigue. Here it says he denies it. Neck pain or stiffness, cough, chest pain, palpitations, shortness of breath. Well, he was short of breath. They couldn't even get the pulse oxygen. And abdominal pain, nausea, vomiting, diarrhea, weight gain, weight loss. Wait a minute. Didn't we have up here he was 159 pounds? And here he was 129 pounds? There was definitely a weight loss. And as a doctor, that should be the number one thing that he should be looking at is, why does he have such a large weight loss? Dysuria, urgency, frequency, hematuria, difficult speaking, swallowing, swollen or lymph nodes, bruising, rash. What else we have here? Extremity pain. Well, he does have feet. He's got problems with his feet of some sort. So why it shouldn't be? He does have extremity pain, swelling, weakness, or numbness. So there's some real problems with this one. That this is when we have conflicting information. When they say no weight loss down here, and up here it talks about the weight loss. Family social history. Past history of this patient is Parkinson's, persistent tremors, elevated PSA, hypoxemia, COPD, hypertension, history of tobacco, sensorineural hearing, loss bilaterally, insomnia, and hyperlipidemia. Family history, nothing's listed. Social history, tobacco, he quit in 2000. Patient, for allergies, patient denies any allergies to medication. This could be really important in a little bit. So, now we're gonna look at this examination. And the examination, alert and oriented ×3. Everything looks pretty good here. Keep this one in mind. He says in the respiratory, he was clear to auscultation bilaterally when he listened to the lungs. Talks about the abdomen, extremities, negative cyanosis, clubbing, or edema. Well, he didn't say anything about his feet. That's why he came in, was for the foot pain. But it doesn't show he did any examination on the foot pain. I kept going through this saying, wow, what is, none of these things, he's got so many different things that are not marked appropriately. Skin, negative rash, warm, and dry. So here is the assessment in the plan. Diet and exercise are all normal. Normal abnormal lab test results have been reviewed with the person. No questions. I don't know what abnormal lab tests they're talking about because they don't show anything. Colorectal cancer screen, patient denies any screening. Get to the diagnosis plan, Parkinson's, and then probably gout. Parkinson's, he never even discussed the Parkinson's. You have to, in order to build a diagnosis, you need to discuss the Parkinson's. And if it's not going into complete detail, at least let us know, is the Parkinson's stable, uncontrolled, no longer a problem, taking the medications to help keep down the tremors or whatever. But Parkinson's was not discussed at any in this service. So again, you need to make sure that if you're going to use a diagnosis, it must be discussed in the history of the present illness. Now, probably gout. Probably. What's our rule about anything that's probable? Probable, possible, or rule. Can we bill for those? No. You cannot bill for anything that's possible, probable, or rule. So instead, you're going to have to go back to the symptom, which the symptom was he had sore feet, or his, when he was swelling at feet, he was having things at nighttime that had a lot of pain to it. But you cannot use probably gout. So as far as I'm concerned, neither one of these diagnoses were proper for this encounter. So he, excuse me, gave him some, his plan was to give him some cream for the probable gout. Check your uric acid level, which would be appropriate for anybody with gout. Return as needed, and approximately 35 minutes were spent with the patient answering questions. Now, this is one of the areas I look at as when the doctor documents time. Is the time supported in a medical record? I do not feel time is supported at all with this because he says there was no questions from the patient. Reviewed abnormal, but he says no questions. There's just not enough information, I feel, to support 35 minutes. I know some doctors can get through this in 15 minutes, other doctors might take a little bit more. But again, I do not feel supported for 35 minutes. So, these are all the different things that I'm looking at to make sure testing was done, but what for? Diagnosis is incorrect. Electronic signature, that's there. He did have a late sign off. Time documentation, instant 2. So again, I would not say either one of these are correct before I even start auditing correct diagnosis. Also, a doctor billed a 99214 for this. No way does it support a 99214.
Melody, should I give you some of the questions that we found in the chat?
Yes.
Okay, let me just go to, there's kind of several of them. I'm gonna go back to this is the last one. Since he is giving cream for flares, we can still consider gout?
No, not unless we cannot assume anything as coders. He said possibly gout or probably gout. That word probably tells us he doesn't know for sure. And when you look at the ICD-10 guidelines say it must be a definitive answer, a definitive diagnosis. This is not definitive. So I would have changed it. I would have gone back. Everybody's got different ways of going back to the doctor and how, if you should or should not change the diagnosis. But I would approach the doctor and say, you said probable. We don't know for sure. He hasn't even had a uric acid test done yet. I feel the diagnosis, instead of gout, so we get this paid, should be foot pain. Then we'll go from there. But no, even though he gave that medication, it does not match the diagnosis.
I hope that answered the question of was that Neil 10. Now he have another comment. My coworker would think the probable might be error.
Error on the part of the physician.
He doesn't have or dictation error.
Could be, but again, we can't do anything about it. You would have to take that back to the physician and let him know what you see, let them change it, but we can't do anything about it. Our hands are tied.
Okay, it has to be cleared then. Okay, there's another question here. It says, is there a hard rule for SOAP format that has to be in SOAP order in the chart note? Sometimes when I'm reviewing charts, I see the assessment plan at the top of the chart note, and then history, ROS, physical exam portion further down in the chart.
Yep, that is just fine. And some are, especially I will see hospital notes that way. They'll put the assessment and plan at the top. No, it doesn't make any difference what order. You just need to know as an auditor what is the history of present illness, what is the review system exam and so forth. But it does not have to be in that order. I would say 90% of the SOAP notes I do are in that order, but the hospitalists I work for, they are not. So no, doesn't that not need to be.
Okay. Questions are just keep on coming. Would you query the doctor regarding the diagnosis or pick up only signs and symptoms?
Well, that's a great question because I have people ask me many times, do we change the diagnosis or what? You must go by whatever your facility, the rules are. There are some, like when I had 15 coders that would do something, we had certain things that they could do and they couldn't do. One of them was they could not change the diagnosis unless they couldn't change the diagnosis, it was something totally different. Or they couldn't charge the E&M if they thought it was lower or higher, they couldn't change that. Some places would say, if the diagnosis is not correct, and it's pretty much there, such as probable gout, if it was one of my people, I'd say, yeah, you could change that to foot pain or whatever. But your facility you work with, they're the ones that have the guidelines to tell you what you can change, what you can't change. You must go by their guidelines. I myself do not believe in changing anything until you talk to the doctor first.
Okay. And then the other one here, does CMS has a guideline on time frame? A note must be documented and signed by clinician or make amendment to notes?
They just have the recommendation 24 to 48 hours. It's just a recommendation. It is nothing that is in writing for it. But this is where your office, the administration, should have something in writing with the providers of how soon they need to have the documentation. 48 hours or whatever. That's something that should come from a rule from your facility. But no, there's nothing that says it has to be done that time. But I can guarantee you, that's one thing, if it ever goes to court or anything, That's one of the things, if you have a doctor who continually has late sign-offs, it's gonna be a problem. Let me give you a quick example, guys, of what I mean by that. I had one attorney one time, the doctor was signing things off very late all the time, and they used to be like 4 or 5 months out. And one of the attorneys was reviewing the document and said, okay, when was the last time you took your wife out for a supper? Oh, it was probably about 4 months ago, we went blah, blah, blah. And he says, okay, can you tell me what she had on? Can you tell me what jewelry she was wearing? What was your waiter's name? What did you eat? What didn't you eat? What kind of wine did you have? He asked all those questions and the doctor stumbled all the way through it. If you can't remember that with your wife, how are you going to remember what you did 6 months ago? It was a great point, and I'm like, whoa, yeah.
Yeah, a very good answer from a lawyer. They're expected to answer that way. They always have an argument to be able to convince you. Well, there's another
That's what they
question
did.
here.
Yeah.
And it says, where does it indicate the provider signed the notes 3 months later? I see a date of service 2/5/21 and signed 2/6/21.
Yeah, that one, yeah. I after I said that, I thought, well, he didn't sign that one off. But that's one of the things I'm looking when I'm reviewing. So that one was not signed off late. But it is one of the things I'm looking at. After I said it, I thought, he didn't sign that one.
Ah, okay, yeah. Okay, so I think that's what I have right now. What is the other here? Okay, from, hold on. From Christy, I often run into providers putting diagnoses in the assessment plan that were not discussed but have labs and order attached to them. I have been told to leave the diagnosis. Is that correct?
Yes, you can put in an assessment and plan, but if they did not address it during the encounter, you can't bill for it. And doctors are very good about doing this, but you cannot address it. It's going to be, especially with 2021 guidelines, very important. So the doctors, even if they in the beginning just say their diabetes is controlled, and then they ordered their metformin or whatever, that supported that they discussed it and everything's okay. They don't have to, just giving me the status of a certain disease is fine. But if I see that often, I know what the person's talking about, they will put, 10 diagnoses down, but they never address them at all during the encounter. You cannot go for this.
Okay.
If
And
it's
the
something-
last,
Oh, I'm sorry, go ahead.
it says Parkinson's diagnosed previously. Is it appropriate to follow the diagnosis from previous doctor's diagnosis, even the present doctor did not document the stability of that condition?
Yeah, he can't list, again, he can't list the Parkinson's as a diagnosis, even though it's a previous condition, unless he just documented that it's normal or, everything's okay. Otherwise, he can't list it. It can be Parkinson's or other things could possibly be a tie to something. But if they did, okay, let me tell you about gout. Gout, there is a connection somewhat with Parkinson's. I can tell you that is true. But first of all, it wouldn't be the primary diagnosis, because that's not why he came in. The gout would be the primary diagnosis. And then he could have put the Parkinson's could be a connecting factor between the Parkinson's and the gout. That's all you would need to say, because he's looking at the Parkinson's when he's giving the like there. But yeah, if it's secondary to something, it would be okay. But you got to put a note in there to let everybody know why it's secondary.
Okay, so I think that's all the questions that I saw here, and the rest of the other we will raise again later on. We'll gather all the questions. Thank you very much.
You're welcome. All right, now let's look at the same patient, but now we have a hospital patient, guys. The same patient they were seeing in the hospital. Whoops, gosh darn it. I'm getting ahead of myself here, clicking. Let's look at this patient. 2 days later, this patient was in the hospital. Okay? They were not admitted by the same doctor. Of course, a lot of doctors do, they're in the hospital office, they don't admit to the hospital. So, but when I seen him, I'm going, well, he was just in the hospital or in the doctor's office 2 days ago. So the chief complaint when he came in was generalized weakness. Now I'm going to read through this real quick. I might skip a little just so I want to get a feeling for it here. 66-year-old male with a history of hypertension, COPD, Parkinson's, who presents for approximately 2 to 3 days of progressive and extreme weakness, fatigue, uncontrollable chills, hypotension, nausea, vomit. Remember, he didn't say anything about being, he said in the doctor's office he had fatigue, but here this is one of the reasons, generalized weakness, that he was brought into the hospital. Wife reports that, patient's wife and son are at bedside and help to provide the history. Wife reports that over the last couple of months, the patient's become increasingly fatigued and weak. EMS was called and the patient was found to be hypotensive with a systolic blood pressure in the 70s. That's not good. He stated the weakness is generalized and not located in any specific area or region of the body. He has a history of double pneumonia in the past, but this event there was no indication or symptoms of pneumonia, which is unlike his previous event where he was diagnosed with double pneumonia. Prior to the presentation to the ED, the patient additionally reported lightheadedness and 1 episode of emesis. He was endorsed some mild chest tightness, but states that the tightness feels more similar to COPD symptoms and may be secondary to missing a nebulizer treatment due to fatigue. So right there, that's one Jennifer endorses an unintentional loss of approximately 30 pounds in the last 2 months. He states this is secondary to his decreased appetite, and his wife reports it's difficult to get him to eat anything, no significant changes or severity with his Parkinson's. We will admit to ICU for treatment of septic shock. That's what he was admitted for. 2 days after that office visit. And you'll notice here the doctor did talk about his 30-pound weight loss. That's something every doctor should know is the very first thing of how much weight loss they have in such a short amount of time. Okay, so here he's talking about, so that's where I highlighted. He talked about the fatigue. He's had it for 2 to 3 days. Endorses the unintentional weight loss, and you're going to admit him for septic shock. So those are the things that kind of came out to me when I, just without doing auditing, just reading the note. On a review of systems, he says negative for fever. Well, he was positive for fever. That was one of the reasons that he was, when he came in, is because he had a fever. Everything else on the review systems, it looks okay. And I don't see any concerns about that. Past medical history, you have everything there, COPD, hypertension, Parkinson's. Past surgery, he had some dental surgery done. Here he puts a family history. Father died at 67 due to Alzheimer's, pneumonia, and alcoholism. Mother died at 72 with a AAA. And brother died at 62 of brain cancer. Then we have her social history. And what's really important here is they have allergies. Patient is allergic to penicillin. In the doctor's office, it says patient denies any allergies. I don't think so. That patient has been seeing that physician for years and years and years, and how it got changed, don't know. But here it's important too. Brother died at 62 of brain cancer. I'm sure, and I know that he probably had some weight loss, I'm sure. So there's something not right here. Examination. Examination looks okay to me. I did notice they said alert and oriented ×3 up here, as well as mood and effect. Those are both sides, so you don't really get 1 point for it. But to me, there was one little area by the physician, hospital physician, that says indicates he feels like he's in a fog and not clear of anything that's going on. But up here it says alert and oriented ×3. So that's kind of contradictory. I'm not sure that would be, one of these have to be, I got a feeling this is wrong, the A and O, and they just don't match each other. If they're clear, it wouldn't be alert and oriented. So. All right, so here they go through all the testing. Here are all the tests that they ordered. The X-ray, that they did on him. He has left mid-lung consolidation, most suggestive of pneumonia, which he's got a history of that. And then his diagnosis, septic shock. They did all the right lab work for it, admitted into ICU, they checked the CT of the chest, abdominal pelvis, checked lipase and all the other things. And he ended up having an acute kidney injury. That was, he has stage 3 kidney cancer, which is nowhere is it documented that, but and not always doctors do it with stage 3 kidney CKD, but he didn't have CKD, so he had kidney damage. He had chest pain, but not sure if it was real chest pain or if it was related to COPD. I'm okay with all of this. Bilateral pneumonia, Parkinson's, and hypertension. Those are his diagnoses that he has. So, what is the difference between the office visit and that hospital encounter? Remember, we have 2 days here difference. Allergies in the office, they said no allergies documented and patient denies. Hospital says patient is allergic to penicillin. Wow, that's a big one. Look how many drugs are used for penicillin. Weight loss, doctor in the office didn't address it. He had a 25 to 30 pound weight loss. The hospital unintentional weight loss noted was really concerning to this physician. On a review of systems, the nurse documented cyanosis along and couldn't get the pulse ox, but and he had shortness of breath. But in the office, they're saying no. Everything was negative for it, but it was positive by what the nurse put down. Examination. This is really important. Office clear to auscultation. Hospital, he had pneumonia. This was only 2 days prior. You cannot tell me those lungs were clear 2 days prior. Where here it says they were clear to auscultation. There's no way. Not when they had severe pneumonia. Enough for septic shock. Now the office encounter, talk about Parkinson's, possible gout. In the hospital, he has pneumonia, septic shock, which is life-threatening. You have sepsis, severe sepsis, and then septic shock. Septic shock is the worst. His wife was informed at the time of admission he only had a 30% chance of living through the night. 30%. And he just seen a doctor the 2 days before that. What is going on? This is interesting. A neurologist seen him for his Parkinson's. He says he doesn't have Parkinson's. He's got an essential tremors. He does not have Parkinson's. When he did the Coglial test on him, he said, no, that's not Parkinson's. He just has tremors. This patient had been taking carbidopa, which causes kidney damage, for the last 4 years. That was prescribed by that primary care physician, and he didn't need to have it. Good part, the patient survived the septic shock. He was in intensive care for 7 days. The wife got real curious about what was a couple of days before, what did they do in the doctor's office? So she asked for the notes. She had gone with him to that office visit, and she said he didn't ask any questions to review systems, all those that they listed in the office. She goes, he never asked those questions. She said he didn't even get off his chair to do a physical examination, as was documented in a hospital or office visit. No examination was done. She said he just sat there at the computer. The respiratory exam, medicine, he said he didn't ask the patient that. He didn't deny anything. He just wrote it in there. So guys, this is where it gets interesting. How does the wife know this information that, yes, she was in there during the office encounter and listened to everything and all of that? This was my husband. So that's why I know all of the information that went on in there, what was asked, what was not asked. This was the scariest time of my life. Thank God he made it through. But he was one sick person, very sick person. There were so many errors in this, and that's when I asked for the notes and I started auditing it and found all of these errors. The point I'm making here is that you and I, we understand a lot of this information. How many people don't know what errors were made on the other end and continue to have problems because of poor documentation? So this is, since I retired, one of the things I've decided I'm going to do is be an advocate for a different type of patients that they have problems. But this is a really scary situation. Documentation's not always perfect, guys. We don't do things perfect, the doctors don't do anything perfect. But it needs to be as accurate as possible. And when that doctor signs that their note, they are saying everything is true and accurate. That's what their signature means. So they must read and reread those notes before signing, and not all physicians do. They can't, or they wouldn't know that if they reread it, they would know some of these things were incorrect. This is interesting that in facts that are published about our EMR systems, that they have many medication errors. That's number one that they find with problems. Copy and pasting and cloning of notes is a problem. They depend on spell check, and that can really change things quickly if it's not spelled correctly. Templates, they have too many templates that are not set up right for the patient's disease, for their age, for their sex. Drop-down menus, they're very limited and easy to get off on the wrong one, to select the wrong dosage or drug. Some of them are just poor design, and this all increases the fraud, the abuse, and it's more than ever compromising healthcare of our patients. So real quickly about copy and paste, people say, is it permitted? Well, some say yes, some say no. What I tell people that is, I don't mind that doctors do some copy and paste, but I think there should be a limitation on what they could do. Again, there should be a rule set up in your facility if the doctors can or cannot copy and paste. One of the things that I do when I audit certain physicians is I will look at, if they're hospitalists, I'll look at 3 days worth. If everything looks exactly the same 3 days in a row, I know they did a lot of copy and pasting. That is one way to determine it. But they lead to things of wrong errors, such as their symptoms, just as that my husband saying the doctor said everything was clear when it wasn't. Medication errors, their histories are incorrect, just like my husband's with, saying he was, one said he didn't have any allergies, the other said penicillin. That could be huge if a patient can't answer those questions. There's so many errors that can happen by things with copy and paste. And authentication of the author. If one doctor documented maybe the total history, the next doctor copies that whole history without consent from the doctor who wrote it, that can be an error and be a problem as well. So our templates, we want to make sure if they're using templates, there's not conflicting information, they're not relative to the age or the gender. We find out some of those, and it is a higher risk to doctors. I'm going to show you an example here. This was a template of a patient, a 9-year-old seen for burn with urination, diagnosed with acute cystitis. The plan, RX meds is directed, instructed patient of safe use of meds, purpose, dosage, importance of finishing the prescribed medication, and possible toxic effects. Increase PO fluids, limit caffeine, wipe from front to back, void frequently, and after sexual intercourse. Patient verbalized understanding. 9-year-old, this area down here shouldn't even be on there. So obviously they didn't read it, but they had a template for cystitis. They should have a template for adult cystitis. They should have a template for child cystitis, male, female. But this obviously wasn't written or wasn't reread to see if there was any errors. But these are the type of errors that can really get a doctor into trouble. Padding of the exam, I talked a little bit before about this, of putting things in there that they didn't need to. So an example, this is one that if they were using, especially 97 guidelines, excuse me, external ears, and this patient had a myocardial infarction. External ears, no gross hearing loss noted. In external examination of the nose, along with the external lips, teeth, and gums. Those are information that really did not need to be in there for a myocardial infarction, but he puts it in every single patient that he does an examination on. Every once in a while it's fine, but on every patient, that is padding of the information you get a higher level. Speech recognition. This is really important too. We have homophones. That's where you have a word that they're pronounced the same, but they have different meanings, such as flower or flower. Are they allergic to flour that they eat? Or are they allergic to certain flowers? That could make a big difference in prescriptions or diet and those type of things. Accept, oppose. We will find different dialects can bring up some difference of words if not clearly stated. One I had, the doctor said pancreas and it came out as pancreas. So you can see it, weird things can happen. So, and that changes the whole medical record in the patient's condition as well. All right, so Jennifer, is this
Yeah.
Okay,
can I just, there are some questions here, and then after that, we're gonna do a short break. So there's one question. If the provider listed multiple diagnoses and he listed as planned refill medications, would that suffice to code all the diagnoses he listed, or he has to indicate each prescription for each diagnosis?
No, if it's in their past history that all he's doing is refilling the diagnosis or refilling a prescription, you're not going to bill for it because they're not addressing it. But he can refill the prescriptions. Just make sure it's documented so you can get points for that he refilled it. Now, if there's a change in that prescription, how many milligrams or other things, then he would want to make sure that he puts something in the history of the present illness or somewhere of what the changes will be. But if he's just filling prescriptions, doctors can do that. Just make sure it's something that's in his history that he's done before. It shows it in the past history.
What about when patient is coming in only for the refill of medication? Will be the diagnosis of that, what is the patient current condition, where the medication is, for what kind of condition the medication is used for? Will it be for that way?
Yeah, well, basically, all they're coming in is for a refill of the medication. That's what the whole visit should be focused on. What are they taking? Are they doing well with it? Are they having any side effects? Putting that stuff in the history of the present illness would be just fine, and then do the refill on it. But if that's all they're coming in for medication, that's what needs to be in the history of how that patient is adapting and what's working well or not working well with that medication.
Yeah. Make sure it got documented that the condition is being evaluated and came up to the conclusion that patient will stay for the same dose, same frequency, or if there's any changes, then that has to be documented too.
Absolutely.
Okay, it says here, do we have to stay for additional questions? Okay, anyway, that's for the... So everyone is free to get up to your seats and whatever you want to pick up. So have your coffee and water, because definitely we receive a very full-packed education here and another more E&M guidelines that we want to be informed for these changes, and we want to make sure that we are up to date and implementing whatever changes in our practice. Thank you. So. Just like I mentioned, we have a special presentation. Our most talented member and former speaker, Vincent, have something prepared for us.
Hi, Jennifer. Is the sound okay?
Yes. Mm-hmm.
Okay. First of all, thank you to our speaker. It's a wonderful presentation. I'm learning a lot from here. Thank you, Melody. And of course, thank you to the officers of the Palo Alto chapter for organizing this. For the uninitiated, Palo Alto is just south of San Francisco. And we dub ourselves the Golden Gate chapter. And March is Women's History Month, and it's very nice that we have a woman speaker. And I am dedicating 2 songs in observance of Women's History Month. These 2 songs are As Long as She Needs Me, popularized by Matt Monroe a long time ago. And the second one is Michelle, which was written by John Lennon and Paul McCartney of the Beatles. Okay, let me try to play for you.
most important is that the documentation for the new guidelines, they're going to need to support the MDM by clearly indicating that patients present encounter their signs, symptoms, illness, status of chronic conditions and history, examination that's performed, any risks, and clearly define those risks in that patient's treatment. So for 2021, 99201 has been eliminated, and 992.211, no change to that one. But the rest of them, 99205 through 992 and 5, those are the ones that are affected with these changes. What's nice about the way they did this is that they cross over as far as what is, so 99202 equals a 99212. Before it wasn't that way, so it is now. But the time is different. The time amount is different for new versus an established patient. So the verbiage change is mainly they took out the wording of these three components and put in a medically appropriate history and or exam and lower level medical decision making. So the elements of the history and exam, they're no longer scored. And when I mean scored, you no longer need so many organ systems, so many review systems, and all of that information in order to get to that level. What you do need, though, is an appropriate history of present illness, a review of systems for what they are presenting for, past family social history. Those must be documented in order to support the medical decision making. So if the doctors don't put any history and exam in there, you're not going to be able to score it because you cannot look at just the medical decision making. They must have that history and exam to support what level they chose for the medical decision making. So here's I'm showing you an example of here what we're talking about for a patient encounter. First one here, this is what you don't want it to say. Here for an ED follow-up visit from last week, pain was resolved and not experiencing the severity it was, but it does give a few twinges. Denies fever, nausea, vomiting, short of breath, chest pain. Limit exam performed, doctor charged 99213, and the diagnosis is abdominal pain. That history up here told me nothing. This is the way it should say. Appearances experienced ringing in the left ear with some mild hearing loss. Oh no, I'm sorry. I thought this was, I'm crazy. Okay, so up here, what he needed to say that he was follow up for a visit last week, ER visit for abdominal pain. The pain resolved and not experiencing the severity, but does get a few twinges. Put in there what kind of pain they were having before so the doctor can know exactly what was going on before. But this information does not give me anything at all of what they were even seeing for. So that's what I mean. It's not painting a clear picture of what the patient's being seen for. Yes, they can look back at the ER notes or whatever, but that's not the point. The point has to be documented for you to charge the MDM exactly what you're following up for. Here's one the patient has experienced ringing in the left ear with some mild hearing loss, no URI symptoms, but does have some nasal congestion and history of allergic rhinitis. He performs nasal washes every day, he's on antibiotics, blah, blah, blah. You can see he's giving us a full picture of exactly everything that's going on with this patient. That's what needs to be there. Now for time documentation, this is one of the first things I look for when I'm doing an audit, that I'm looking if there's a time. And so if they are charging this visit on time, I know what to look through on the note when I'm looking at it. So it includes face-to-face and non-face-to-face time personally spent by that provider or a qualified health professional, such as a PA or NP, time on the date of service only, not before or the next day. You cannot count that, only on the date of service. And clinical time cannot be counted in that as well. For the time documentation, they need a statement of the total time of the encounter. And then You guys want to make sure you're muted, please? And then activities that were performed to support that time. So when I talk about activities, I'm going to say, you want to say something like patient, I spent 30 minutes talking to the patient about diet and exercise and how to help keep their diabetes down and what is considered high and low and what they need to avoid. I mean, talking into detail, giving the detail of what you talked about in that time frame. That's what you need for the statement that is performed of what activities were performed during that time. It's not, they don't need to put in there, and if they do, they're doing it incorrectly. That 50% of the time is spent counseling, that means nothing on this new. You've got to put down what information and counseling that you performed. All right, so this is the MDM grid. You guys want to make sure you have this handy so that you can follow along with the rest of this presentation. At the top of it, you can see all of these categories. We have 5 of them. Code and the code and time, level and MDM, number and complexity of problems addressed, elements of MDM and amount and or complexity of the data to be reviewed and analyzed, risk of complications and or morbidity or mortality of the patient management. So this is where we're gonna talk about all these columns as we go through here, and these are all used to help determine the MDM. So the first component, first one of the time and code, what this when I say column, what this column means is it's going to put down the new patient code and the time. So that will be 99202 is for 15 to 29 minutes and so forth. Then the established time and codes for established patients. Now what I'm going to tell you right here, see this URL down here? If you go and you look up this URL, I'll tell you it will have everything I've talked about in this thing. It's all documented by the AMA. They're the ones who put together the new E&M rules. But everything I'm talking about will be on this information. So I highly recommend it. I always keep it by me. If there's a question, I know exactly where to go get it. Now we're going to talk about the columns of level of MDM, number and complexity of problems addressed. Level MDM, it's going to tell you it's minimal, low, moderate, or high, the level, depending again on the level of the code that you're using, and the complexity of the problems addressed. So on what that means is that you're going to have, on this particular one, if you look at the very first, well, look at low. When you look at the low one, it says 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Now, what the AMA did, when you go in to look at that URL that I showed you, it will talk about, you say, well, what is considered a chronic illness? It's going to give you the definition of it. And what they define as a chronic illness, this is an illness that acutely worsens, poorly controlled or progressing with an intent to control progression and required additional supportive care, or requiring attention to treatment for side effect, but does not require consideration of a hospital level of care. So that's telling you what it is a chronic illness. If this particular one for 99203 and 99213, it says a stable chronic illness. So they might have chronic illness, but it's stable. This one down here is talking about an illness that is worsening or poorly controlled. So again, looking up that information really helps you to understand what they're talking about in this complexity of problems. So when we look at this right here, this is the complexity of problems. Here it says stable, but down here says chronic illness with exacerbation. So again, you can go right into that AMA information and look up these comments. They can tell you what it means. And that's really helpful. I still look at them. The fourth component is the element of the MDM, amount and or complexity of the data to be reviewed and analyzed. This is all going to be determined by the data of ordering, performing tests, reviewing results, interpretations, and discussion management. We're going to go into detail about these in just a few minutes. Then the risk of complications, this is going to be based on the consequences of the problems or the conditions that they have. It can be determined by patient's management criteria, level of the risk by nature of that presenting problem, and also the thought processes of the provider. This is one that we all will struggle with. Doctors sometimes are not really good about writing down their thought processes. You know, when they used to dictate, and all of our doctors used to do it, they could think about it. I can still see doctors with their eyes closed, talking into a dictaphone, writing down about the visit. Now it's a click, click, click. They're not as good at writing down their thought processes. Okay, so now we're going to look at that full line all the way across for the minimum. It's a straightforward code, 99202, 99212. Problems, one minimal self-limited to a minor problem. Amount is minimal or none, and risk is very low. This one, there's not much of a change to it. I mean, it's just, let's say, example might be they come in for a recheck of otitis media, and everything's clear. There's really not much to it. Some got, you might have a few here and there, but it's not used as that often. Now we have 99203, 99213, the next column and next row. This one is, you have complexity of data. Oh, wait a minute, I'm not sure I didn't. This one, we have complexity of data. You can see that the terms on these here. For low, it's two or more self-limited or minor problems, or one stable chronic illness, or one acute uncomplicated illness or injury. Now, this is where it gets different. With the complexity of the data, this has been the biggest change and adjustment for our providers. First thing I want you to note, it says limited must meet the requirements of at least one of the two categories. Here's category 1, here's category 2. So it must meet this category or this category. Now under category 1, it is either tested documents, Category 1, tests and documents. Now, it has to have, in order to get this category 1, they must meet at least 2 of any of these 3 that are listed here. And I'm going to go into detail about what these all mean too as well. So this category 1, you either need to have review or prior external notes from each unique source, or review of the results of each unique test, or of these in order to get category 1. Or category 2, assessment requiring an independent historian. So it can be either one of these. It can even be a combination of I mean, if they have category 1 and category 2, that's no problem as well. But that's what it means. And then with the low risk, we're going to go over the low risk here in a minute. Okay, so now let's look at this complexity of data that's in this 99202 or 99203, 99213. When they talk about category 1, again, we need 2 of any of the 3 of the following. This is an external review or prior external notes from a unique source. So the external records, communication, or test results are from an external physician or a QHP. QHP stands for Qualified Healthcare Individual, facility or healthcare organization. Example, they must clearly identify what information was obtained, where did the information come from, and who provided that information. So here's an example. The doctor might say, I was able to review the DEXA performed at ABC facility, and there is a considerable decline from the previous DEXA performed 5 years ago at the same facility. Then the doctor would want to list those scores as well as the dates that it was performed. That is what is a review of an external note. Again, this is real tough teaching the physicians on how to document this correctly. But if it's not, they're not going to get points for it. So you need to spend the time with education. Review of results of each unique test. This one you're going to receive credit for ordering the test, but not for the review of it. So if you ordered it, it's all one CPT code for ordering it and for reviewing it. So if you're ordering your analysis, you only get 1 point for that ordering. The CPT code includes the ordering and the review. Okay? Now, let's say you ordered 4 tests, and all of them were you reviewed yourself or whatever. You count 4 points there, not just 1, but 4. If you ordered them and you reviewed it. Category, whoops. Oh, okay. Now the category 2, that's requiring independent historian. Now this is where, and the doctors love this because they never, especially in pediatrics, I have a huge pediatric group I audit for, they never got points for, mother answering for, or father answering for child or whatever. Now they can, but they need to document. So it's an individual, so it's your parent, guardian, surrogate, spouse, witness, who provides that history in addition to the history provided by the parent or who is unable to provide or complete reliable history due to either developmental stage or dementia, psychosis, and it's a confirmatory history is judged to be necessary. So some people say, well, if it's a baby, of course mother's going to give their history. I understand their point, but per the guidelines, it must be documented who gave that history. Keep in mind, sometimes it could be mother, it could be grandmother. I've even had siblings bring in their younger brother and sisters, father, babysitter. It could be anybody, so you can't depend on that. You have to document who the history came from. And I've even had children with ages that have been really young that have given their own histories and stuff. They're very intelligent kids. So you must put down who the history came from. So in order for complexity of data, you need either category 1, and that's 2 within that category 1, or category 2, where it has independent history. That's how you document that level for MDM. Now the risk level for this is it's a self-limited or minor problem, runs a definite course, prescribed course, transient in nature, not likely to cause any type of permanent health status. So we talk about otitis media. They have a virus. What's other things they have? It's just something that just doesn't take very long. They have sore throat. They have strep test. Things are very simple. I see this one used again quite a bit. All right. Now we're going to look at a 99204, 99214. The problems and complexity of this is it's one or, for a moderate, it's one or more chronic illness with exacerbation, progression, or side effect of the treatment, or 2 or more stable chronic illnesses, or one undiagnosed with problem with uncertain prognosis, or one acute illness with systemic symptoms, and or one acute complicated injury. That would be more like a concussion or something. And again, those definitions of what those mean, look at that AMA information I gave you the URL for. Now, for the moderate MDM complexity of data, kind of the same as the one before, but just a little bit different. So before category 1, we had category 1 and category 2 in 99213, 99213. Now they combine their category 1 with assessment requiring independent historian. So this one now, for this level, you need 3 of these in order to get category 1. So again, we talked about those external notes. All of this is exact same definition that we just run over, but they are including the independent historian in this category 1. So you need 3 of any of these following. Or category 2, independent interpretation of tests. Now, this is where it means that there's a CPT code and an interpretation or report that's customary with it. So they might have, let's say they're looking at a EKG, that is, you have the code that they're using is for the test and the interpretation. That's when that's, let me read this here. So I sometimes get confused myself. You guys know how this is. This does not apply when a physician or a qualified healthcare professional is reporting the service or has previously reported the service to the patient. So what this is that they ordered the EKG and they did that on that first day that they did it. They're not going to get a higher level for this if they've already done that. They've already done the EKG, they've read it and that type of thing. And it's not for a physician that trying to think here a second. I want to make sure I say this just right. Any form of interpretation, if they're doing an independent interpretation for something, it doesn't need to be really a formal report. But what I see sometimes the hospitals do, one doctor, you'll have one doctor, maybe it's the radiologist who wrote something, and then the hospitals will come in and write, in my interpretation, blah, 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 blah. So that's what it is. It doesn't have to be really a formal interpretation. It's just their interpretation of the test. For management of test interpretations. So this one is, it's with an external physician or other qualified healthcare professional, appropriate source, not separately reported. So these are healthcare, they're not healthcare professionals, but they might get involved in the management of the patient, such as a lawyer, parole officer. We're using probably more and more parole officers. Professionals that may be involved in the management of the, may not be involved in the or they are involved, such as the lawyer and the parole officer, but it does not include discussion with the family or information caregivers. So they're doing just more, I don't see it used hardly at all. It just is such a, I don't know, it's just a little bit confusing, but I just don't see it used much at all. Or category 3, this one I do see, discussion of management or test interpretation. This is an appropriate source, including professionals who are not, they are healthcare professionals, but they may be involved in the management of the patient. So sometimes they might be, they're asking a physician about, they had such and such test done, or it could be, think here, another person. it's not in the same group practice, right? So if you have two internal med docs talking together, it's not that. It would be somebody who's not in that profession. Maybe they've seen a cardiologist. They're going to call and talk to that cardiologist about what was going on, what is the problem, get that information from them. So it's really kind of two different areas, discussion of management or testing treatment. So it is two different areas. Now the risk of complication for 99204-214. This will include drug prescription management. This means they are identifying the prescription that's ordered. They want a different quantity, dosage, or just a refill. Any of those things qualify for prescription drug management. But as we were talking right after the break, that they need to do the prescription, have it at least if it's a past medical diagnosis that this is the prescription they're taking, and now you are refilling it. If there's any problems, identify that. If they change the dosage, identify that. So it is for any not over-the-counter prescription drugs. Discussion regarding elective major surgery without identified patient or procedure risk factors. So, and then let me go to the next one, but explain the difference in them. Decision regarding major surgery with identified patient procedure risk factors. So, with your consent forms are what all the doctors say, the patient signed the consent form, blah, blah, blah. What they need to do on these consent forms is they need to identify if they have risk factors. They not only need to tell the patient, they need to make sure it is in that surgery, surgery procedure that they give the patient for them to fill out the sheet. You must identify what those risk factors are and make sure they are documented in that surgery report that they give them for them to sign. When they say yes, they want surgery, identified in there. So if they don't have any, then it'll say without identification. But this is new for 2021, making sure that identified risk factors are identified with the patient and they're documented. If they just documentation of risk factors viewed with the patient, that is not sufficient. They have to identify what those risk factors are. This other one that's really new for 99204 and 99214 is economic social conditions that limit treatment and further diagnosing, such as housing, mental disorders, literacy, caregivers, history of drug abuse, anything that influences the health of the people and the communities around them. So these are going to be things that the patient is homeless. So this is very hard for them. They're not getting the care that they need, and that's why it led up to this. They have a drug abuse problem. Maybe they are clear and they are clean now, but you still would put that down because that does put them at a higher risk, even though they've been clean for a year, that they could slip backwards. So those are all different economic type of conditions. I had one just the other day. I was reading a hospital note. The guy had lived in his car. He was homeless. Been living in his car for 7 weeks, and he didn't have any food. He didn't have anything to hardly drink. He was just getting snow off the ground and using it for water. Because he had no place to go, and it's been cold here. We had some below zero weather. Staying in his car, he didn't have any gas in his car, but he wanted to die. He decided this is the best way for him to live, is just to die in his car. And when a policeman checked on him, he ended up taking him to the hospital. He ended up having his one foot amputated because of frostbite and that type of thing. That's a social condition that he didn't have control over because of his social environment. So that will give him a higher level as well. 99205, 99215, this is the highest level. It is one or more chronic illness with severe exacerbation, progression, or side effect. And then, or it can be one acute or chronic illness or injury that poses a threat to life or bodily function. These could be things such as a myocardial infarction or MI, COVID, that they have an exacerbation of COVID, respiratory failure, which many of these COVID lead into respiratory failure, sepsis, suicide ideation. That's going to be affects their mental status. So somebody might have a stroke and they have a mental status too, that has changed their mental status due to the stroke. These are things that must be documented that are very a threat to their life or bodily injury, or very chronic illness with a severe exacerbation. Remember, the ones we have they have an exacerbation or a chronic exacerbation. This one's a severe exacerbation. The middle column, again, we have the three same columns. Okay, so category 1, just as the one before, review of prior external notes, review results, ordering unique test, assessment requiring independent historian. That's all in number 1, category 1. They need 3 from that following. Or independent interpretation of the test, where they do their own interpretation. This one now, category 3, is discussion of management or test interpretation. So this is give you an example of this one. We had a patient that came in that was bleeding, had rectal bleeding, and they thought they got the bleeding stopped. The doctor told the patient in urgent care, he said, if you have more bleeding, go right to the emergency room. Don't come see us, go right to the emergency room. The next day, he had extensive bleeding again. All of his clothes were soaked with blood. He didn't want to go to the emergency room, so we went back to the urgent care. The doctor in urgent care, after talking to the patient, found out that he had a colonoscopy a couple days before that. There were some concerns with the colonoscopy of some polyps they found. So he called the gastrointestinal doctor and talked to him about, if we have this internal bleed, where he wanted to go, blah, blah, blah. So he called another doctor to get his opinion about his patient, because he knew his patient was seen by him and there were some problems with it, and to get his opinion on it. So they sent him off to the emergency room and he was admitted to the hospital. So that's a discussion of the management or test interpretation with the other doctor. High risk, this is a high risk category, high risk of a substantial duration, limited function, impairment of quality life. That could see where a stroke would fall under that category, or organ damage based on presenting problem. So in the case, the one I just talked about, the rectal bleeding, he had some organ damage there that was causing his problem. Long-term or short-term intensive monitoring for adverse effects, and many times that might be like chemotherapy or something like that. Decisions requiring major risk factors and comorbidities or other injuries that may impact that surgical outcome. So again, that surgical consent must have that information in there, what those are. Emergency major surgery due to urgent nature. Keep in mind that these are not something that's been a scheduled event. This is an emergency type of surgery. Decision for hospitalization. That would be a great one for the physicians that are hospitalists that take care of the patients in emergency room. Of course, they're not going to be able to charge for emergency visit and hospital visit, but that is one of them. Poor prognosis resulting in DNR or to de-escalated care. There's many times you see a patient come in, they've been deteriorating for the last 3 weeks, they bring them in, they discuss it with the doctor and say, we don't know what else we can do. They're 96 years old and they say, we're not going to, we want them to be a DNR. They're de-escalating, we want to make sure it's a no DNR. Now quickly we're going to talk about the scoring of it. With the old prior to 2021, this is how we scored it. We had the diagnosis, complexity, risk, and you would go with the one that was in the middle. So this one was a 2, a moderate for risk, 4 or more for complexity. We would go with the middle one. But in 2021, it's going to be decided on this side. You have a moderate problem, a limited complexity of data, and a moderate risk. It's going to be a 99204 or 99214, depending on if it's new or established patient. There's another one that could be a high. I rarely see, just in a regular office, I rarely see too many highs. If I do see a high, it's usually due to a time, not due to the condition of the patient. The only exception to that is somebody's having a heart attack in the office, they're calling EMS to come in. That one may be a high, but for the most part, it's many of the things have been based on ADHD or ADD. People that have a long discussion of time. Maybe it's for an elderly person that is experiencing grief reaction or something like that. But that's where I'm seeing more of the higher levels is on time and not so much on being seen in the emergency room. Now, this is the other thing quickly I want to tell you about time. Make sure your doctors are not scheduling everything on time. And I'll tell you why. Because what they are finding is some doctors are charging everything on time, and if they add up the time in the day, they'd be in the office 24 hours, or they'd be in the office 20 hours. They know that's not right. So I really highly recommend doctors not to use time only when necessary, but not on every time. Just my 2 cents worth. Okay, to quickly end everything, I'm going to do some real quick medical humor for you guys. You got to laugh for the day. That is the best medicine that you can have.
I'm laughing now. That's the best therapy.
It is. Okay, remember we talked about homophones? When they say something and they come out differently? These are some real examples of homophones. Patient 23-year-old female who presents with a headache and bitten tongue. Her parents, the patient has a history of grand mal seizures. A 9-year-old female with a history of remote middle cerebral coronary stroke, should be cerebral coronary stroke. Walking Leona instead of walking pneumonia. And the patient had a hard time breathing. Should say breathing. So we see all kinds of things like that. Here are some funny, humorous errors that have been documented. Indication for a flex sig, patient blood when whipping himself. Reason for leaving AMA, patient wants to live. He's allergic to wives instead of hives. Asking about DNR status, I want my wife to receive artificial insemination. This was 2 OBGYN doctors talking. They said, between you and me, we ought to be able to get this lady pregnant. The lab test indicated abnormal liver function. You can see how that could be easily that O for an I. Physician asked the patient if he smoked. Doctor documented, like Bill Clinton, he does not inhale. And testicles are mildly prominent. It was a brain MRI. So sometimes people are writing these. I mean, have you ever written something down and think, oh my gosh, I can't believe I said that, or whatever? You're just not thinking.
Oh my goodness.
This is the funniest one I love. This 56-year-old patient brought to the ED via ambulance with diabetic ketoacidosis. Wife states that he's been complaining of nausea, vomiting, and abdominal pain. He is a type 1 diabetic and not under control with his diet or insulin regimen. Examination, upon exam, I found a moon pie hidden in his underwear. I'd probably be me. So, in closing, guys, our physicians need our help. They need to learn to document these thought processes up here onto the paper. That's where we need better answers. And those who did dictation should remember how to do it. That's where, don't rely completely on the EMR, personalize it, add your thought processes, because we can't dig in that head unless it's on that painted, it's a painted picture in the note. They are not taught this stuff in medical school, so that's where we have to go in and help them so they get paid for what they do. That's what we want to do. So educate them on proper documentation. I don't educate them on coding. I educate them on documentation. So that's when I go into them and say, I don't want to teach you any coding. I want you to teach documentation. Let us do the coding. That's our job. Remind your physicians, just because you got paid for it doesn't mean you're going to keep it. It all depends on your documentation. That's put the monkey back on your back. So thank you from Loveland, Colorado, Sweetheart City. It's been a pleasure to be with you guys, and I hope you got something out of this presentation today.
Yeah, there's still a lot of questions here. Actually, the first question, Neil 10, he actually asked, did you order any books regarding auditing? He's kind of interested if there's a book that you wrote, and he's ready to get it.
Well, I taught for NAMAS. You guys know who NAMAS is? National, NAMAS is, I helped them write their book. So they teach a great auditing class. That is one. Anybody's got any questions, and I can give you information. You have my email here. You can email me. Just make sure you let me know where you're from. But they have a great auditing class for you to take to prepare you for the CPMA. I helped write that book. I did write one at one time, but I haven't updated it because I'm retired now.
Yeah, like give me a break.
Yeah, I have a husband that's not a healthy person, so I'm spending more time here.
Okay, there's another question. A physician does a med review for chronic conditions on a patient in a nursing home with dementia who can provide a HPI and is resistant to an exam. He reviews the facility medical record with the nurse and will make changes, and proceeds to list all 10 plus diagnoses or more than 10 diagnoses. How do you determine the MDM for those kinds of visits?
Well, again, he's got to put down that he addressed the issues, not just, it's probably something I'd have to look at for sure. Sometimes it's kind of hard without looking at to see what is there. If that person could email me and give me a little more detail, I'd be more than happy to answer their question. You're muted.
We'll send the attendee, that's Bridget Race. Okay, we'll give her your email, or we can forward her question to you, and then you can just respond, and we'll forward it to her. Okay, and then there's another question here. Would you mind asking my question? I am adding a little more context to it. If, for example, on a visit completely unrelated to hypertension, in the plan, the provider put in the I-10 DX for refill along with diagnosis related to the visit, but the I-10 was never mentioned in documentation. Can we add the I-10 to the claim?
That one's a little bit too much information there for me to send that one to me too.
Okay, I'll send that one too. Okay, and then there's another one. By the way, Vincent, there's a lot of them saying that was an awesome performance.
Oh, thank you. Great.
It says here, hold on. There's already a request here for you to speak for their chapter.
I don't know how many more I'm gonna do, I'll tell you.
Just tell them, I'm already in retirement. Jennifer, just catch me. Okay, here you go. I'm scrolling down all the chat here. Okay, time documentation for critical care. Do we need start and end, or is total time documented by MD is okay?
The
I got
law
it.
for critical care, you said?
Yes, it says here.
The doctor just, you know what, I don't, everything I've seen, nothing says you need to know, you need to do start and end time. You just need to document, I spent 35 minutes with the patient and making sure that the condition that they have definitely fits the criteria for critical care. Something that's a life-threatening organ system damage or whatever. Just making sure that that's what they are there for. But just the amount of time, just making sure that it was documented. The only problem I have when somebody does the time type of thing is when every doctor, or one doctor, every time you see somebody in critical care, is 31 minutes. Every time. That's a pattern. And I don't like it. So.
Yeah. And then the other question